Well, let's make a start, I think. Welcome, everyone, to the Bartlett Together Festival 2021. Today, you've joined this session, Pop-Up Healthcare Architecture Using Disruptive Design. My name is Professor Kerstin Saylor, and I will lead you through this event today. The session will be recorded and added to the faculty YouTube channel, the Bartlett Together website, and will be forwarded to registered attendees. We encourage you to submit a question for us as speakers at any point during this event. You can click on the Q&A function on the bottom of your screen, and you can either submit your own question or upvote others. So please make ample use of that. We will hear a presentation first by a series of speakers, some of my colleagues who've joined me today. And then in the second half, we will follow this with a Q&A, and then we will end the session at 5:30. So, pop-up healthcare architecture using disruptive design. I'm from the Bartlett School of Architecture, and I'm joined here by a wonderful group of colleagues. That's Peter Scully, also from the Bartlett School of Architecture. Then we've got Professor Duncan Wilson from CASA, Professor Grant Mills from the Bartlett School of Sustainable Construction, and Dr. Anne Simmons, also from the Bartlett School of Sustainable Construction, Professor Paul Foster from the UCL Institute of Ophthalmology, and Dr. Harry Jayaram from Moorfields Eye Hospital, NHS Foundation Trust. So what we want to lead you today in this session is work we've been doing over the last year, looking at how we can help as people in architecture, design and construction, in spatial analysis, to think about how can hospitals be designed differently, and how can we help tackle the backlog of appointments in the Moorfields Eye service. I will hand over to Professor Paul Foster, who's going to start with an overview of the background of the situation. Over to you, Paul.
Great, thank you, Kerstin. I'm going to try to put in context the situation that we had in Moorfields treating our patients leading up to the start of the pandemic, and then my colleague Harry Jayaram's going to lead you through the actions that we've taken to try to improve the situation and help get our patients back into healthcare settings and restart the clinical services for patients who have missed appointments. So just to start with, the UK's NHS, National Health Service, is a huge organisation. In 2019-20, the service saw over 96 million people. And it might be difficult to imagine, but actually the biggest sector of the NHS is eye care. And this isn't opticians on high streets. This is hospitals providing eye medicine and surgery services. Next slide, please. And myself and Harry are glaucoma specialists. And so the disease that we treat is a disease that affects the nerve at the back of the eye. And left untreated, it can cause loss of vision, that you can see illustrated in these 4 panels here. You can see the top right one shows early damage, the bottom left moderate, and the bottom right advanced damage. And glaucoma is the commonest cause of irreversible blindness worldwide, affecting something like 60 million people and blinding between 6 and 8 million people. It affects about 1 person in 50 aged, just go back, Kerstin, please. It affects about 1 person in 50 in their 40s and older. Just back to the previous one. So it affects 1 person in 50 in their 40s, and then in the over 70s, it affects 10% of people, and currently absorbs about 1 million visits per year in the NHS. Next slide. And so when patients come in to see myself and Harry in clinics in Moorfields, the usual system is that they report to a reception desk and then they're asked to sit down in a waiting area. And then they might be called up to have some tests like this visual field test you can see at the bottom of the panel. They might go and sit down again, then get up and have another test on a sight reading chart, sit down again in a waiting area, and then be called into an examination room where they might see a nurse, then an optician, then a junior doctor. And if there are problems, they might then see a consultant, one of the senior medical staff. And there's a range of outcomes that they can then follow. Many of the patients that we see remain stable, and they'll just be booked for a follow-up appointment, or if things look absolutely fine, they'll be discharged. Some patients go for surgery or have medical treatment, but a large number of patients that we see are just having follow-up checks. Next slide, please. And this is based on some work we've done with UCL's Department of Applied Healthcare Research, looking at the projected number of hospital appointments if a senior doctor like myself starts seeing patients and gets 10 new referrals per week, and then brings patients back at a range of different intervals. And these intervals, the proportions are based on what actually does happen in our clinics. And you can see the caseload for that single senior doctor with their team grows inexorably. It just grows year after year after year. And this illustrates the problem in the wider NHS, that the workload is just growing in an uncontrollable fashion. But that's in the context of many of our patients remaining relatively stable. We can't discharge them out of the hospital. And what we really need to do is to keep them under occasional hospital review and just check that they are still stable. So next slide, please. And so with that aim, we back in 2013, we set up Clinic 1A in Moorfields, which was really a repurposed waiting area. And we set up the clinic to be a sort of a linear flow mechanism. So you can see on the floor plan, we've got green waiting areas on the left-hand side, and then this sort of long, thin examination area where when patients come into the clinic, they visit each machine in sequence, going down the line, and then once they've had a test on each machine, they leave through the door at the far right-hand end. And this allowed us to shorten the journey time from over 2 hours for most patients in a normal clinic down to around about 45 minutes. And we modeled this system on one that we had developed for research, where the type of research that I do mostly is looking at large numbers of people in the community, and we've developed efficient systems for testing people. So this was based on one that we first used in a cohort in East Anglia called Epic Norfolk, and then used in UK Biobank. And if you read the quality press or listen to Radio 4, UK Biobank's usually featured about once a week with a major story. So it's the UK's largest biomedical research study. We've done a variety of research projects on the data that we gathered from Clinic 1A and eventually produced clinic standards to outline how these rapid throughput clinics should be run. Next slide, please. And the clinic was so successful that it was actually moved to new quarters. So it moved into our Caton Street clinic, and it currently provides about 10, or pre-pandemic was providing 10% of our clinic capacity. You can see some of our technicians here. And in fact, we're developing a new class of hospital staff. So these are technical staff who are trained to use the examination equipment in these high throughput clinics. And so that was the situation just before we went into the pandemic, that about 10% of our patients were going through clinics like Caton Street. Okay, thanks very much.
I'm taking over here from Paul again, and we'll report on a research project we've run to understand the current practice. So how do two different clinics, the one that Paul just introduced in Caton Street, and an additional hub that was set up after the pandemic or during the first wave, the so-called Hoxton Hub. And both of these are operating at the moment in parallel. And we were interested, as an architect interested in layouts and design, I was wondering how these two are performing. So we observed care practices. So I went in with a team of observers looking at the flow of patients through those clinics. So just to run through how they are laid out, you can see in Caton Street, you've got the examination stations arranged in those two rooms. And in contrast, the Hoxton Hub, you can see that linear flow model really clearly put into the layout. So in Caton Street, you've got these two rooms, and the stations are in both of these in an open plan kind of dotted around. Paul has already told you a little bit about the eye examination. So just to visualize that again, patients would have an eyesight test, and you can see the stations marked in the floor plan. Then their glass prescriptions will be checked in a so-called visometer or autorefractor. Then there would be a test at a station called Aura. The next test at a station called HFA, so this is a field analysis, and then the last test called OCT. So you can see here how the Hoxton Hub is really arranged linearly, logically, kind of 3 lanes, and patients would flow through one of those 3 lanes, one side in, the other side out. And in Caton Street, you can see in the layout that it's a little bit more open and a little bit more pooled in that sense. So observing on several days, more than 1,000 of these, I think 1,100 in total, patient examination processes at these stations, we could see the mean duration and the variation of duration that patients spend at those stations in both of these clinics. And you can see that the duration is actually quite different on the different stations, with the HFA being the longest, but also quite a distribution in the data. So you can see that they're not always, the same amount of time that they take. Sometimes the variation is quite considerable. So that's the first thing we found, that there's quite a bit of variation in the durations. What we were then interested to see was how does it flow throughout the day? So you can see those 4 charts now, the top row for Caton Street, the bottom row for the Hoxton Hub, and patients are aligned on the x-axis and time of the day on the y-axis. And you can see how patients go through the system, and each patient receives a series of tests, one after the other. At first sight, you can already see that the Hoxton Hub is a bit more regular. So the examinations tend to happen in a similar or in that pre-described order, and there's a bit more variation in Caton Street. However, we have to say that in Hoxton, we've only ever observed 4 patients being in the clinic in parallel. So the clinic was not under so much stress, whereas in Caton Street, we've seen a maximum of 8 patients in parallel. And you can really see that here in this part of the diagram. And if we zoom into that area for Caton Street, you can actually see quite a bit of variation and quite a bit of waiting times occurring. So this is when it gets really delays occurring for the patients, because there's so many patients in parallel and they are blocking stations that are already in use. So here we can see how the Caton Street, with the arrangement in the open plan, creates some of those delays because the next station is just not available. We've also looked at the flow, and we were quite interested to find that the flow in these two clinics really resemble the spatial layout. So you can really clearly see how patients coming into the entrance, then flowing from one station to another, and you can see the thickness of the lines here representing the numbers of patients going from one station to the other. How the two layout systems are reflected in that. You can clearly see the linear structure of the Hoxton hub and the more kind of free-for-all, slightly more complex system in Caton Street. Caton Street is also complicated by the fact that you've got these two different rooms. So we've drawn up a visibility graph analysis here, which shows what you can see if a technician would be sitting at station number 2. So all of the orange areas is what they can see immediately from that station. All of the yellow is then the next kind of step, and then all of the green, the next step after that. And you can see that once you're in one area, the other examination area is 2 times around the corner. So there's limited visibility between the two, which also explains the lack of flow between the two areas. So if you're in one area, then patients tend to stay in that particular area. With that, the next step then for the team was to think about a new type of clinic. And some of my colleagues will be talking about this some more. So there's now a new clinic that has been opened, a pop-up clinic in the Brent Cross shopping mall, in a retail unit that was no longer used for the retailer. And I just want to explain the spatial principles before then handing over to my colleagues to talk a little bit more about the processes and what was happening there. So you can see that the clinic, you walk in and there's these pink check-in points moving to a corridor. And in the graph, you can see how the flow, how the spatial principle is laid out in the flow. So there's 2 big innovations happening here. One is that the order of the stations is different. So you can see that the autofractor comes first, but then there's much more HFA stations. Remember, those were the longest ones and longest examinations. So those are now 6 of those HFA stations coming from 2 autofractors pooling into those 6. And after that, you move into a lane system where then the patients go through eyesight, aura, OCT, and a wide field analysis before then exiting the clinic again. So it kind of combines what we see as the advantages of the Caton Street system on the one hand with the pooling, but the linear flow of the Hoxton hub. We continue to monitor how this is running. It was opened with a soft launch in September, so the first few patients have been going through that system. With the continuing to monitor this, I will hand over to Duncan, who is going to talk to you about using sensors to monitor the situation there.
Thanks, Kirsten. So hi, I'm Duncan from CASA, the Centre for Advanced Spatial Analysis. And I'm really interested in how we can use technology to help us understand how people use spaces. So in the context of this, what we're really interested in trying to do is to augment the work that Kirsten has just been talking about, which is kind of observational studies of how people move through the space, and try to add in some continuous, if you like, longitudinal monitoring. So permanently monitoring the flow of staff and patients through the space. So we're working with a fantastic company called Uvisense, who have an ultra wideband sensing system. So down at the bottom left there, you can see these 2 little beacons that are side by side. They're located around the room at the different locations on the maps, the dots and the arrows. And what they do is they provide, if you like, kind of beacons that are sensing the tag that you can see at the bottom of the screen with a little red strap. So what those beacons do, they're all fixed in location, and the tags themselves move around, and the sensors detect where that tag is. At the top right of the image, at the very, very top right, you can just see one of those sensors installed on the ceiling. It's kind of pointing down. The little image at the bottom right is kind of some of the secret sauce of this system, which is that all of these beacons all plug in together into this timing unit. And it's very time sensitive, capturing these sensory pulses coming into this system that's in a server rack. Have the next slide, please. So kind of what does this, so how does this system actually work? So essentially all of those beacons are basically listening for the tags, and they take two parameters that allow the system to understand where the tag is in 3D space. So they use this thing called two-axis angle of arrival, which is basically multiple receivers are basically receiving the signals being broadcast out from the tags. And it's also using time difference of arrival. So it's literally just seeing how long it takes a message to get from tag to receiver. From all of that, there's some clever maths all happening within the software on the server that's basically then in real time, about 4,000 readings a second, is able to calculate where these tags are. And these are all things that can be manipulated. Also, the tags themselves there, you can see there's some stats in terms of the size and weight of them, but also these are all IP-rated tags, which allows them to be cleaned thoroughly between use and such like in this environment. On the next slide. Okay, so what does all that allow us to actually capture? Well, you can probably tell from what Kirsten was describing, we're kind of very interested in understanding where the flow of patients through these different zones, but also staff as well. So we're kind of interested in kind of where staff are having to move between different locations. So the intent is that staff and patients will basically wear one of these tags, and there's a whole process for registering the patient when they come in and assigning a tag to them. They then wear that tag through. In this case, you can see there's different stations numbered kind of 1, 2, and 3. And every time that tag in effect enters into those zones, we're capturing that data. So this kind of does give sort of very, very fine-grained detail on every patient that's coming through, which is kind of what's kind of interesting. There's also there's things like the station 4 there, the loss prevention. We also have things like we need to make sure that the patients don't walk off with these tags, and so, but given that we know where they are and when, we also have methods for being able to detect when they're leaving the premises as well. So I'll hand over to Peter now, who I think is going to talk a bit about the layout of the actual physical infrastructure.
Brilliant. Thanks very much, Duncan. So my name's Peter Scully. I'm from the School of Architecture, Programme Director for Design for Manufacture. And when we first started looking at this, one of the things that's really quite obvious is that some of the things that both Duncan and Paul and Kirsten have been talking about are variables of a system that we don't know everything about yet. So Duncan's sensors are going to be giving us data that are going to give us operational models for the flow of people, how to get the highest throughput and the highest quality of clinical need to be able to inform a design for the layouts and flexible walls. So the idea is how do we manufacture a flexible walling system that allows design to happen after the event of manufacturing? So it's looking at a modular system, and modular systems have been around for ages, but Cedric Price generated project. He's really looking at how do we conceive of use and allow every variation on use to fit within a nominated grid pattern. Next slide, please. So the initial plan that was come up for the layout, and this is a kind of a day one solution for the flow of people through there, was the layout that we can see on the right here, based around a 3-meter grid. And the 3-meter grid is really to allow us a clear overall system understanding. It also allows for any system that is designed in terms of flexible walls. It allows anyone to reconfigure the design, not just an architect or a manufacturer, so non-professional design decision-making. Obviously, easy reconfiguration and easy services integration, but quite importantly, aligned to supply materials. How can a design be rationalized so that it wants to be made with readily available materials? Next slide, please. So design process went through to really look at what are standard supply materials and how do we generate a design that is fit for purpose on day one, but is also reconfigurable around a 3-meter grid and subdivisions down to 1500 and 750. So the needs are low cost configurability, highest product to materials yield. So a conversation with Moorfields very early on, and us asking us, can we use this as a vehicle to be able to shape supply markets or shape supply thinking around sustainability? So the design here actually utilizes a UN-survived net zero material and with zero waste. And then looking for wider supply bandwidth of supply chain, minimize uniqueness, and so on and so on. We're really looking for what are the attributes of a supply chain that can be exploited to be able to deliver need. Next slide, please. So the ultimate solution that is now installed up and running in Brent Cross is not the most exciting piece of architecture. It's a very standard walling system that you can see, quite commonly. What is more unique is how that it is flexible to the clinical need. It delivers clinical need on day one, but it also is a learning system. So the variables that are coming out from Duncan's systems and from the technicians on site learning, from the clinicians on site learning and Kirsten's systems is allowed, that information is useful for the reconfiguration. Next slide, please. But there is detailing at a very, very discrete level of manufacturing, this negative corner on the panels, which unfortunately hasn't been incorporated into the final on-site delivery. So this is research, this is a learning point as well. But that corner basically guarantees uniqueness and reduces wastage by 50% and install time by 20%. It's a determinate detail that allows maximum reconfiguration of the pieces. That needs adhering to, and it's something that the research has pointed out that we need to detail, we need to make sure that is adhered to. Next slide, please. Just to finish up, I think from a design for manufacture and assembly perspective, what we do see very much in architectural solutions in all different markets is that solutions, so our houses, our buildings, our infrastructures, are generally detailed and solved with a mind of the supply chain. What ends up happening there is that the supply chain offers up interest-based solutions. The role of DFMA in here is to be able to use the intelligence of manufacturing, but not use the motivations there. And if the DFMA, design for manufacture, value add can be added across the supply chain, across the contract boundary, we start to look at informational symmetry across contract boundaries. An awful lot of revenue is generated in many projects that is principally derived from informational asymmetry. If you know something, you can charge from it. But if you spread design information right across the supply chain, we really start seeing a much healthier, a much more competitive and user-orientated supply chain, even for healthcare. And I'm going to hand over now to Grant. Grant, thanks very much.
Thanks, Peter. What's really interesting, I think, from my own perspective, my name's Grant Mills, I'm from the School of Sustainable Construction, is where do we start when we start to deliver projects? And how do we start to engage with our client to understand what it is that we're delivering and what is that process that we must take? There's quite often a rush to procurement, and we quite often need to get this project underway and delivered. And what we got in this situation is we got a really exciting and interesting brief that came from the client, Harry and Paul, that was starting to identify the opportunity to learn about how to build this new diagnostic pop-up centre. it started to challenge the way that we were thinking about delivery. Just as an example, when we started off, we realized that many of the standards that were being used by many other clients and projects across the UK were using quite outdated standards. They were standards that were, in some cases, 25 years old. And what we really saw is we saw these new technologies that were being developed at a pace that needed to learn, and we needed to innovate in the way that we were delivering architecture and systems that were advancing the flow of patients through and creating value. I suppose the most important thing is to think about how we're creating value. Well, as Paul said in the very beginning, we're creating value for the patient. We are not expecting them to sit around for 2.5 hours waiting to move in and out of rooms when we can move them through a process that could take 45 minutes. We're starting to think about how we can increase the flow of patients to acquire more data that would allow us to solve more diagnostics challenges using more advanced AI, machine learning, and also to develop new technologies. So I think the important question is how do we create these interdisciplinary relationships that are advancing availability for the patient, increasing quality and convenience, but also developing this better process that is good for everyone. Next slide, please. So what we're doing is I'm working with a number of colleagues. So we have a PhD student who's doing work in applying discrete event simulation to understand the queuing around two particular solutions, which is a linear flow and then a pod style of configuration. We're working to try to re-envisage a pathway that moves beyond a linear flow to asking patients to move into a space, a pod, which would allow the sequence and process of the technology to be better controlled. We saw during that design process that lighting and light was a significant influence on the way that patients were using this setting and being able to use some of the technologies. These patients are moving through 5 pieces of technology. Each piece of technology is slightly, there's a variant in the way that the light is impacting each of those pieces of technology and the disruption that it's causing to the patient potentially. So what this is starting to envisage is a new way of thinking about the arrangement of the setting, and subsequently that leads us on to other thought processes about how we might clean air, how we might create that setting in which people are waiting, how we might create better level of satisfaction for staff and for patients in that environment. Within this setting, you have quite often dark lighting, which means that staff and patients are in this dark setting. And so the advantage of the pod may present an opportunity for staff to be in a lighter setting with patients in a controlled pod setting that allows staff and patients to have a variation in lighting. Next slide, please. So what is the potential and what is the impact? We've talked about this really critical opportunity of reducing the potential eye loss of patients. But in terms of infrastructure, the critical thing that I can see here is what are we investing in, which is allowing patients to get treated quicker and diagnosed quicker, which will reduce the cost ultimately to the whole healthcare system. If we get quick diagnosis in this lower acuity setting, then patients can go home and manage their condition much more effectively. If they aren't diagnosed, and given that we have significant backlogs that Paul talked about previously, then those patients will start to move into higher acuity settings. They'll start to move into hospitals and require more frequent visits. They'll require more aids and devices they'll require more informal care. They'll require care in nursing homes. And so the important thing for us as kind of infrastructure professionals or building and architectural professionals is to really think about how we can work with intelligent, advanced clients like Moorfields to innovate in the way that they can quickly diagnose and quickly move patients through the system. In that process, I think it's really exciting to think about what is health in the high street situation that Moorfields are starting to consider. How are hospitals starting to innovate, not just in acute settings, but moving into other primary care settings, and raising questions about what does it mean for hospitals like Moorfields to be alongside other brands like Apple, like John Lewis and Tesla on the high streets in a locality like Brent Cross. Harry, I pass over to you.
Sure. So if we can move on to the next slide. So thanks, Grant, and thanks everyone. Now, as Paul mentioned, I'm one of his colleagues at Moorfields, and we look after patients with glaucoma in particular. And I want to try and, just to finish off, bring this full circle. So we're going to bring this back to where it all came from, which is patients. And patients with glaucoma are generally older. They'll be your parents, your aunts, your grandparents. And I just want to talk about things before COVID, because things have been pretty bad during COVID. They weren't great before as well, if I'm being honest. So if we just go to the next slide. So as Paul mentioned, we have a population that are living longer. We are getting better at health screening, so more people are being diagnosed. So we have this constant population that need monitoring, and maintaining timely follow-up for patients was really, really challenging throughout the country. And there were some very, very high profile cases that were front page of the national news and national media, where young patients had lost sight just because they'd slipped through the net for their appointments had been postponed and rebooked. And the bottom line is quite simple, that the demand exceeded the capacity. So from people who provide services to patients, our main challenge is, we need to live within our resources, but somehow, the true NHS motto is, we want you to do more for less. And that's it's this, again, I think maybe this fits in with the sort of austerity that, we are likely to face in the future. So if we can just move forward to the next slide. So when COVID happened, we, within the glaucoma service, had to, on a day-to-day level, just tear up our timetables and redesign how we delivered care. With hindsight, my rose-tinted spectacles would say that the pandemic provided us with a huge opportunity to innovate. One of the things that facilitated with this was that within the NHS, we were allowed to innovate. So we were allowed to go out and talk to Grant and Pete and Kirsten and everybody and come up with these ideas. Whereas beforehand, I think we would have been quite constrained. You could argue that without Zoom and all of us meeting, there's 206 people on this call. Without the pandemic, would we have adopted to such big gatherings and connectivity together? I don't know. So what we did was, Paul mentioned those clever new innovative clinics that we designed. Now, in reality, before COVID, 80% of our patients were still in traditional face-to-face clinics. And these were overbooked clinics, long waits and packed waiting rooms, which clearly wasn't an option with social distancing. So to increase our capacity and try and redress that equation I showed before, we rapidly increased our diagnostic clinics or virtual clinics, and that's where by senior medical staff. And in the long term, even now, as we emerge from the pandemic, we are having to still do this. So I think at the moment, we're in the fourth bar on this chart. Around half of our patients are seen now in a diagnostic virtual setting. And really, this is why, the driver for what I'll touch on later, this concept of diagnostic hubs. So if we go to the next slide. During, and you can put the next one up as well, actually, Kirsten, I think there's two on, maybe three actually. So like I said, the pandemic gave us scope for innovation. We did several things. We our first priority was risk stratification. We needed to make sure that we looked after those patients at greatest risk of sight loss. And then, in reality, we were making clinical decisions about balancing the risk of sight loss from glaucoma against the risk of death from COVID. Because those of you that were in London at the time, you'll remember how the pandemic literally was on a rampage through the city during that first phase. And we had obviously had to protect our vulnerable staff as well. So it's not just the patients. Now, if you just go back one slide, Kirsten, the guidance from our Royal Colleges were quite limited. So we sort of saw more and more complex types of patients in virtual clinics. And we redesigned different types of clinics also just to try and touch base with the patients we'd cancelled. So, because we'd cancelled 40,000 appointments a year ago. So, it was crazy times. So next slide. So now this really moves on to what is the way forward, I think. So diagnostic hubs, if we go to the next slide, this is really raising the question, can we perform this sort of monitoring outside of a hospital setting? NHS estates are limited. And actually, patients don't want to travel into central London. Patients don't really want to go to hospitals. Can they go somewhere where they can drive to? And that's where really I do think this is the future, because diagnostic hubs is something that I spent the whole of this morning on a pan-London healthcare NHS call about diagnostic hubs. Everyone wants to do it. We are fortunate because we've got the money through the research setting to be able to innovate and try this, but the whole country, whole city and the whole country is talking about this theme. So it's something to certainly be aware of. If we go to the next slide. So we talked about Brent Cross. So Brent Cross, if you haven't been, it's one of the biggest shopping malls in the within the M25 region in North London. And Kirsten, if you flick through these photos, so Kirsten may have shown some of these before. So this was sort of how we wall prototypes that Peter and his team came up with. And if we go on to the next slide. And this is what it currently looks like at the moment. So we've got, sort of state-of-the-art eye clinic inside a shopping centre. And this is very relevant. Not only is it, really bringing together, quite contrasting disciplines of, science and architecture and healthcare, but it's really the way forward certainly for looking after our patients, and actually for Moorfields as well, because we're in 5 years' time, we're going to be moving to a new site near King's Cross, just beyond the Crick Institute. And lots of the learning, I think, that is coming from the work that we're all doing now at Brent Cross in this project, I think is going to be relevant to the architectural future of eye care in London, as well as delivering care to all of our parents, aunts and grandparents in the years ahead. So thank you for your attention. Thank you for joining us today. And I think we're all happy to take any questions.
So Harry, Kirsten asked me to marshal the questions. So
okay.
I'm just gonna go through the Q&A panel that we've got here. So Bob Shield has said, to what extent are you investigating the design of spaces for eye care that incorporates all the senses, touch, smell, hearing, not just for the patient, but also for the staff who spend their working hours in these environments? So I'm very grateful for Bob's interest in the staff well-being, because, Harry and I do spend extended periods of time in clinical environments. Although the concept with this design of clinic is that it's not going to be doctors and nurses that are the major part of the workforce. It's this new group of ophthalmic technicians who we are gradually building up a career structure and a training system for. But it does it does become very important when the staff are in these environments for 7-8 hours a day. For some staff, it's much longer than that. I mean, some of the medical staff are in the hospital 12, 14, 18 hours a day sometimes. So I don't know whether any of the other faculty have perspectives on that. I know Grant touched on the design of lighting, and I know that Peter we've had conversation about the tactile experience within the new clinic at Brent Cross. So does any other of my colleagues have views on that question? We have had conversations with another UCL colleague who has suggested that the softer aspects of design may be important and relevant. This chap's called Nick Tyler, and Nick runs the Pearl Laboratory, which is UCL's new environmental modelling facility in East London. And Nick was one of the people who was keen that we look at some of the artistic and more creative options for enhancing the experience. Harry, I know that we've had conversations about staff satisfaction, staff motivation, reducing staff turnover. I think that's a key to the success of these clinics.
Yeah, I mean, I think Bob's right. Happy staff. Any job you're doing, if you're in a work environment that you're happy, you will perform better. And one of the sort of side projects we're trying to develop is this concept of team incentivization within the workforce. One thing that's really interesting, just very briefly on the workforce side, is the kind of people we have working. These are all people who have lost their jobs due to the pandemic. And we've deliberately tried to recruit people who have communication skills and are quite patient-centered, because we can teach anyone to use a machine, but we can't teach people to be empathetic and be able to listen to patients. And what's interesting about the workforce is their motivation to join was, yes, they've had employment issues, but B was the portrayal of the NHS over the last 18 months. They just want to give something back and be a part of it, which is, it generally brings a tear to your eye when you talk to these guys. But happy staff are definitely, it's always a good thing.
Great, thanks, Harry. So I'm just going to go down to the third question on the panel, Noor Mubashir. My question is regarding the spatial analysis of the clinic. Some patients are at higher risk of glaucoma or maybe already blind. Shouldn't they have a separate space or area and be treated separately compared to the spaces provided for which people are in the initial or earlier stages? So I'm just going to touch on that, and I'll then maybe boot the question out to the rest of the faculty to comment on. The concept of the Brent Cross Clinic is focused very much on early stage disease. These people are more likely to be the working age or younger retired group with early stage disease. And if we can get the milder, more straightforward cases out of the hospital, that then frees up resources for the more advanced, complex, more elderly, frail patients to be dealt with in a traditional hospital environment where their complex needs can be more easily met. Any of the other faculty have any views on the?
Paul, Peter, I think I've got something to speak that speaks to that, but it also speaks to Bob Shields' comments before that. I think one of the things that's striking about this project, and possibly why it is motoring so fast, I think, is that there's a certain duality to it, in that it is solving like a day one need. We do need diagnostics, to soak up the backlog and to get things moving. Okay, but it is also a research opportunity. This, Brent Cross is in a lot of perspectives, it is a learning opportunity. So, Design for the Walls, is there to be responsive to learning that happens in delivering day one need. So let's see what the response is of throughput going through. Let's see what the data from Duncan is about throughput. Let's see what satisfaction is like. Let's see what people feel in those spaces. Sort of levels of anxiety or levels of comfort. The eye, the level of light that's in there. It's often the case of design is that we've got to get it right first time. I think the beauty of this project is that it is good as our knowledge is on day one of delivery, but it has also got the capability to learn and to respond and to increase learning. And I think that is probably the key component of the whole project for me.
I mean, Pete, I don't know if we've emphasized enough that there are going to be 3 iterations within that. So I think that's a good point, just to make it clear, what you saw the pictures of is iteration 1. That's going to be torn down in probably 7 or 8 weeks, I think, and over a weekend magically transformed into something else. And, the third one, none of us have any idea what it's going to be, because that's going to be data driven, depending on the analysis from all our colleagues here, as well as the health economists, because at the end of the day, this is public money, and it's all about getting, like I said, the NHS doing more for less and efficiency.
So Bob's been busy on the keyboard. There's a few more questions about the experience of the occupant. Now, I can offer some perspective, and I'm sure Harry will have some views on this. In healthcare, particularly in UK healthcare research, we are now focusing on what are called patient-reported outcomes. So, for instance, a big clinical trial of disease treatment that I was involved with, the main outcome measure in the clinical trial was the quality of life experiences of the patients. We do collect, obviously the standard medical numbers and measures, but increasingly we're looking at, what the patients tell us. And so we're very lucky to have the UCL Department of Applied Healthcare Research, who specialize in this type of patient-reported outcomes, using questionnaire tools, focus groups, engagement with patient representatives, etc. And I know, Harry, this is more your specialist field.
Yeah, I mean, it's interesting. It's a good point, Bob. But the NHS, one of their other little nuances, and this is a sort of standard interview question for anyone for an NHS job, is what's the definition of quality within the NHS? And it's a 3-pronged thing. It's basically care that's safe, effective, and with high patient satisfaction. So to implement any change in the NHS, you have to address all of those 3 issues. So Paul talks about patient reported outcome measures. So these are certainly validated questionnaires we're doing. And the other slight variant on that is called patient reported experience measures. So we're trying to understand the patient experience, such as, how did you feel you were treated at the clinic? How did you find traveling to the clinic? What feedback could you give? And this is a huge part of the outcomes for this project. And of course, the other important thing is, because we're doing 3 iterations, we can incorporate patient and staff feedback as to how to improve things for successive iterations, so that this will all be incorporated as well.
I think that's a really good point, Harry, is that quite often we only evaluate at the end. We only evaluate in architectural terms, as Bob was describing there, at the end of a project. I think what's really innovative and exciting about this project is it's evidence-based as we go along, and we're starting to innovate and to review and consult in that kind of co-created process. We are measuring as we go, and we're measuring from different perspectives. So it's kind of an integrative measure of people's satisfaction, staff and patients. And if we take it back to the very beginning, patients in a waiting room for 2 hours isn't a setting in which they would like to be. I think you hit it on the head when you talked about the new higher quality situation that you've got in Brent Cross, which is trying to move patients through these settings in a way that they understand, and that is as quick as possible and as convenient as possible for them to move through those settings. COVID impacted us in so many different ways, but waiting in waiting rooms is not a situation that anyone wants to be in at the moment. And they don't want the kind of traumatization of thinking about going to a waiting room and sitting around with others. And I think it's such an innovative way to think about, how do we move patients through, in a happier and more well-considered, scientifically informed approach to design that is taking into consideration impacts of light, impacts of noises, and so I think it's a really interesting project.
Yeah, and I think just to kind of add into that as well, I think there's, Harry was mentioning that the 3 different phases that are going to be explored, which will be able to allow us to test 3 different layouts, 3 different ways of working. So they're all kind of very different. But actually, one of the goals of doing the longitudinal monitoring is just to try and understand, is there a difference day to day? A Monday is different to Fridays. Is there a relationship with the weather? Is there a relationship to what's going on in Brent Cross at that point in time? So I think there's lots of opportunities for trying to look at and observe the differences that we see in the numbers, so to speak, and to see if any of those things could lead us towards thinking about the environmental conditions that are actually changing the experience that patients and also staff are kind of feeling within that space. So I think there's fantastic things for us to explore there.
If I can add to that, maybe Bob is kind of asking, how can we turn a clinic into an architectural research opportunity? And I think that's exactly at the heart of what we're trying to explore here, is to look at the realities of how the clinic is running and to observe current practice, to intervene into the situation by providing designs that are movable, to then think about how does that change the supply chain, how does it change the implications for how care is delivered, of how we're potentially changing patient outcomes. And if we were to do it again, if we were to ask architects, how would you design the next clinic? How would you design the next hospital? Is to be able to give some answers to that. So I think it's a fantastic kind of life research opportunity where the clinic is both the starting point and the medium and the outcome of that process. I've got 1 more minute. I've been asked to keep a watch on the time, but I think Grant and Paul, you were both trying to come in here.
I was just going to answer the last question that we've got in the panel. It says, since the walls are flexible, would there be any problem with patients' privacy or demand for soundproofing? Remarkably, in eye care, privacy is not a very high priority. Harry and I work in open plan clinics. This has been the case for 30+ years in Moorfields, which is the Western world's biggest eye care clinical facility. It doesn't seem to provoke any particular problem, so it's a good idea. But for eye care, it's not a hugely pressing issue. I think we're
Peter, you looked as if you wanted to do some final wise words.
I don't know how wise they will be, but it's just summing up really that the opportunity that we're in is very, very unique. And it's just responding to Bob's thing about an architectural research area, is that it's so valuable that it is research and it is delivering real world need today. So I think that for me is a really powerful part of this research.
Well said.
Good last words. Maybe we can draw it to a close here and thank everyone for contributing and coming and asking questions. And I think it's time for us to say goodbye, and you will hopefully hear more from us in the future.
Okay, thank you.
Thank you.
Thank you.
Thanks all.